Okay, so we're doing a quick study session. We got our agenda items here, right? So we're doing meds. All right, we want to know what kind of meds we have to know for the test. So IV push meds. What are your 6 IV push meds you have to know? So metoclopramide. So I would separate this into GI ones, right? And non-GI ones. Because the non-GI ones are unlikely to be tested on, right, on the exam.
They're not.
Okay, what are your GI ones?
So not the EKG one.
Which EKG ones did I give you?
On your PowerPoint, there was.
So for like this, I'm talking about like the 6 ones you've got to be checked off on, right? So those, but yeah, there are IV push EKG ones, right? So let's put EKG ones, right? Those are EKG IV push, right? You're not check off, right? But these are ones that you should know, right? But yeah, going back to GI stuff, what's some other GI stuff? Yep, pantoprazole. That'd be over here under non-GI, right? Methylprednisolone, what else? Famotidine GI, right? Anything else?
You have the non-GI, or I don't know if it's GI, the LASIK, the furosemide.
Yeah, furosemide will be non-GI. What's the other one? It's non-GI. What is it? Cephalosporins, right? Cephalosporins. It's usually ceftriaxone, right? So these ones are not on exam, right? Do you have to know it for your checkoff? Yes, you do. Right? Therefore, your skills checkoff, where you're learning how to administer these ones. There's the math attached to each one, right? Not exam, but for checkoff. Skills checkoff. Where you need to know the math, you need to know it inside and out, right? You know all the things about it.
Something like this, for the math.
Okay, yeah.
Incorporate it into like but closer to.
You can do math. Right, so yeah, so for GI meds, these ones you need to know for exam, right? Know for exam. So I've given you the side effects of pantoprazole. I've given you the action of these of famotidine. I've given you all the things about these GI meds, right? So these ones you want to know inside and out. Okay, and then EKG IV push. It's not a checkoff, but you need to know these, right? And what are some IV push EKG meds? Good. So adenosine. 6-second half-life. What else? Good. Atropine. Amiodarone is IV push and then it's a drip. It depends where it can be. Yeah, so we just put ABCD meds, right? ABCD meds. Right? But adenosine, epi, and atropine, those are your usual ones you give IV push pretty commonly. Epi's given when? Yeah, so bradycardias and when there's no pulse, right? So there's no pulse with VFib, no pulse with VTach, no pulse with torsades, no pulse with asystole, PEA, et cetera. All these things require epi and what other intervention? Yeah, CPR and epi, that's it, right? And we have other options if it's like VTach, right, without a pulse, or torsades, right? We have other treatment options. Right, so last time we didn't finish the EKG table, but hopefully someone did, or that you use it as a bouncing off point where you know that I have to know my lethal rhythms, and my lethal rhythms, they have, CPR and epi is the default, right, for each one, but some of them I have to add on a few things, right? Which ones do you add on a few things?
For the third.
Besides CPR and epi, what else are we doing for the lethal rhythms? CPR and epi is all you do for. Let's go back a sec. Well, what are so just put EKG stuff right here. So EKG questions, right? So there's, CPR epi, right? Is for who?
For all pulse.
It's all you do for.
Oh, for pulses.
No.
For.
No. It's like it's the only thing you do. Other ones you have other options, right? So CPR epi for all the rhythms. Just CPR epi for who?
From, for VFib, no?
not VFib.
Oh, who's the patient?
Mhm.
Oh, asystole?
Good, asystole, and which other lethal rhythm?
Oh,
I feel we need to make a table. PEA, very good, all right? So I'm not sure if anybody grabbed this one, EKG chart. So this is the one that's not editable, and then I gave you one that was editable. That way you had a solidified version. Yeah, I want you guys to upload what you've made into these folders too. That way we have, all right, so lethal rhythms. So let's real quick, what are your lethal rhythms? So you got VTach, right? So VTach, right? So VTach, you have pulseless, right? Let's just put with pulse, and VTach without a pulse, right? All right, so it's called pulseless VTach, right? And then you have polymorphic VTach, right? Which is, right, polymorphic, right? Which is torsades, okay? And you can make this neater to fit the table, right? And then we have our two other ones, which are our three other ones. We got VFib and we have PEA, right? So when you have, so with this column right here was treatments, right? Under the last one here. So you can see, the priority for all lethal rhythms is CAB, right? So it was ABCs, airway, breathing, circulation. Now it's CAB, it's circulation first. That means CPR first, right? And then airway and breathing. So for asystole and PEA, it's just what? Good, CPR and epi. That's it, right? So that's all you do. Right? There's nothing else, right? Nothing else works. Yeah, nothing else works. So CPR, you're going to compress them until you can reverse the what? So under here, I think it's causes, right? Causes. I should probably, that's the second column. Try to redo that sometimes. All right, so causes, right, are what for lethal rhythms? H's and T's, right?
Oh.
So H's and T's are the cause for every lethal rhythm, right? Right. And the cool thing about these are reversible. H's. How many H's are there? Five H's and 5 T's. You can make it 6 sometimes for each one.
points, and it's like.
Yeah, so H's and T's are your reversible causes of lethal rhythms, right? So we have those options. Those are the treatments that you're going to be throwing in there, right? Because we know that what causes torsades is low mag, right? So we'll add low mag is different, but low mag, prolonged QTC. Yes, so we got other options. You got mag, right? As another option for VTach with for torsades. Okay, so VTach with a pulse, you give. I mean, these other ones you're going to give. What other medication starts with an A? You give with a VTach without a pulse. Amio, right? You have that as an option, right? For VTach with a pulse, what medication do you give? No, that's going to make the super tacky. No, ABCD meds only work for the AV blockade. VTach is a ventricular rhythm, but a little asterisk, one of those ABCD meds also works on ventricles. Not calcium blockers, no. Digoxin's only works in the AV node. Digoxin only works in the AV on the vagus nerve. Which one of the ABCD meds also is ventricular?
No.
No, atropine also works on the vagus nerve. No, there is one beta blocker that does work on the ventricles, but beta blockers, and that's the right answer. So amiodarone is the option, right? If BP is good, right? If BP not good, what do you do? Can't give amiodarone because to make your BP low. That's one of the side effects, right? So BP not good, less than 90. what do you do?
You give them fluids. No,
Fluids is, yeah, that you might, if you worked in the hospital setting, you're like, blood pressure's low, give fluids, give a bolus. Yeah, that can work. It can be temporizing, but the best thing is to, fix an underlying cause or to give to kind of get them out of that rhythm with what? Good. So what is it? So synchronized cardioversion, right? Because you've passed medical therapy at this point. You can't, all the medicines we would give cause low blood pressure. Right, so we can't give any more blood pressure. We can't give any more meds once their blood pressure less than 90. So someone has VTach, they have a pulse, right? So they're responsive. They would have chest pain, shortness of breath, or confusion, right? But as soon as they hit the hypotension threshold, that's when they need to get a synchronized cardioversion, right? Whereas VTach without a pulse, what do?
you keep it.
It's VFib, which is called unsynchronized cardioversion, right? VFib.
Also, with the
Don't care. You don't care if it's synchronized or not. You want to just shock them out of that lethal rhythm, right? And then, yeah, torsades, same thing, unsynchronized cardioversion. Cardioversion. VFib, do you shock VFib? Yes. VFib, right? Right, do you shock CPR asystole? No, that's it. CPR and epi. That's all you got to do, right?
Is it because there's no pulse or there's no like electrical?
There's no organized electroactivity. It's not, well, technically PA is organized, but yeah, movies are going to be different.
I like the video you added of that one show, and it's like, oh yeah, we got normal rhythm back, and it was like.
Yep. All right, so yeah, so if you don't know lethal rhythms, you want to know lethal rhythms for the test, right? These are lethal rhythms that are going to be tested every semester, right? So you need to know them inside and out. Next semester, you'll go over the order in which you do these, right? You don't just hit amiodarone, unsynchronized shock, CPR, epi, right? And you're going in there going, shotgunning it. There's an organized approach to that, right? That's what's called ACLS, where you do it, there's like 2 minutes in between, 3 minutes over here. After 3 shocks, you give amiodarone. It's a whole thing, right? And you'll have a whole sim on it in MedSurg 3. Right now, and now in MedSurg 1, you're learning just you're just learning what the treatments are. Okay. Yeah, that's MedSurg 3, you do ACLS, where your patient has a rhythm change on the monitor, right? And what do you do next? Right? And you have to act, right? You might have the knowledge, right? You have the knowledge like, oh, we got to shock them. It's like, you're like, Alexa, shock, right? So that doesn't work. You have to actually put the pads in place. You have to actually do it.
The reason that we have around is because the other medications can lower the blood pressure even more.
So yeah, so if someone has VTach with a pulse, right? You can give medications, right? There's medication you can give, right? If you're fancy, you can give lidocaine is another option too, right? But all these medications are going to lower the blood pressure. So we have to, BP is not good. We have to then give a shock of some sort, right? And if they have a pulse, you don't want to shock them on the T wave because now they're in torsades, right? So that's that, or even going to VFib. The synchronized, yeah, the machine knows, right? And the way it knows, it has it'll say sync on it, or you'll see little markers above the R waves. Mm-hmm. Mm-hmm. Yeah. Mm-hmm. All right. This is already shared with you. So yeah, if you made your own table, please upload it here to the So under this is the folder I shared with you, right? If you haven't favorited this yet, please favorite it. And under exam 1 prep, right? I put down stuff where you can upload your study stuff, right?
I'm just showing them
Mhm.
the first one I found was polymorphic.
I'll tell you, is this one. It's after.
51.
Yeah, when we start talking about VTach, ventricular rhythms in the slides, that's where we talk about H's and T's, because that's the treatment, or that's the causes, I should say, right? It's causes / treatment, because H's and T's, each one of them has a treatment attached to it, right? So yeah, so here under upload your study stuff, right? So you can just drag and drop your stuff, right? So I put out one that you can edit already, okay?
But the one that you're doing right now, it's just got space.
That's under, yeah, it's safe, it's locked, right? It's not gonna be edited, right? It's under the study session from last time, all right? Does that make sense? Are you guys EKG'd out? Do you still want to do? I think the next segue was talking about what kind of EKG test questions there would be. See table, right? So again, that's why if you can draw that table out, right, 4 times for your friends, then you're going to get it exactly on the test, right? So you need to be teaching the material, right? It's one thing to just read it, and then that's called a bypass surgery, right? Where you read it, it just goes right passes your memory centers, right? Or you just verbalize it past your brain, you're just verbalizing it. So that's just going notes, mouth, notes, mouth, notes, mouth. That doesn't help, right? It needs to be, in your hippocampus and your limbic system, and you need to be able to actually convey that material, right? So that's why study sessions work the most. That's why something like this would work the most. I mean, I'm quizzing you right now. I mean, we can get you up to the board and start drawing things too. We can do that if you like, all right? Where you start drawing things on the whiteboard. In Zoom, it's not gonna be, I can make Zoom actually share, you can actually draw stuff on Zoom too, right? I can make it, you can annotate freely. All right, so that's you're sharing it, right? So you're teaching the content, right? When I teach the content, I learn like 4 or 5 things new every single time, right? I start making connections, right? Even though I've learned this material so many times, I know the material, but it's still I start making connections. Like, oh yeah, that's how that works, and that's how that works, right? So it's going to be stressful for your brain to grab the information. That's why you want to do it closed note, right? From whatever you do remember, it's like, hey, there's these lethal rhythms. Like, oh shoot, I forgot all about VFib, right? So then next time you're not going to forget VFib, right? You don't forget what you forgot, right? So yeah, that's the idea, right? That you are trying to make errors ahead of time, right? It's just like a piano player, right? A piano player practices ahead of time. They don't just read their notes, read their notes, read their notes, read their notes, and then now it's time for performance on exam day, right? You have to practice that performance, right? And before the exam day, you might not have a perfect performance. That's fine, right? As long as you're like 95% there, that might get you an 85% or 80%, right? We don't know, but what the correlation is. But that's the idea, is that you are practicing the material, okay? So you can just say, hey, let's do lethal rhythms, and then let's do atrial rhythms, let's do sinus rhythms. That could be your whole study session, right? For 2 hours, 2.5 hours, right? You're all just going over EKG stuff and learning inside and out. Okay. And you can break it up. You can have like 3 study sessions in a week, because this was last week, right? Right now you should be working on GI, right? So you should be doing like, hey, we're doing pacers and blocks. And for this study session, this next study session, we're doing sinus rhythms, atrial rhythms, right?
You know, so we were not, the way that they were teaching us, it was not to stay with us. So now we're learning with you. Because I see the difference between your students that had you and us. We're like lost and they already know.
Yeah, so learning EKGs that's why I tried to make sure that you are understanding what's going on and how it works, right? So there's some method to all the scribbles on the pages, right? And all the pictures I'm giving you, right? They're not for you to memorize. They're to explain the concepts, right? Again, this is nursing theory. That's the idea behind the theory, is the theory behind how something works, right? That's what theory means, right? Is how does it work, right? If it was just like nursing material, it was just like, here's AFib. Good luck, right? Make sure you can vomit this on exam day, right? That's not how you learn, right? So yeah, so you do have a disadvantage, but that's what I'm trying to get you guys up to speed as much as possible, right? So yes, but your focus for this exam again are the blocks and such. But again, I told you you have to know your lethal rhythms, right? There's at least 2 or 3 questions just on lethal rhythms. Okay.
So we're also being tested on like the atrial rhythms as well.
Yeah, just like your EKG quiz that I gave you. I'm not sure how many people have uploaded their quiz yet, but that's due tonight, right? Is that what I gave you, or is that right? Yeah. On ExamSoft. All right. Once you graded it, it uploads it. Yeah. Let me know if you don't feel it is. I can check to see if yours is uploaded. Right. Usually doesn't let you. I mean, once you hit submit, then it uploads automatically. Okay, so that's the idea. I was trying to give you like today's as your done day with EKGs. That way you can, at least for a week, focus on GI stuff if you haven't already. Okay, so you've had 2 weeks theoretically for EKGs, right? All right, so yeah, so that's what EKG test questions are gonna be geared for. So no lethal rhythms, right? Lethal rhythms. Okay, so that's, it's recognizing, oh, right? So that's lethal, right? And then what am I gonna do about it, right? What are the causes and treatments, right? And its causes are H's and T's, and the treatments are what? H's and T's, trick question, right? So, but it's also CAB is a priority, right? So yeah, so the priority is to start doing CPR and someone's like, hey, he came in with a heart attack, right? What should we do? And that's where they can think about how to fix the heart attack, right? Or he came in with hyperkalemia, what can we do, right? And you learned about hyperkalemia treatment over MedSurg 1. I'm not going to test you again on like IV push calcium chloride or something like that, but that's just so you know that the treatment is to fix hyperkalemia, right? That's one of your H's, right? It's hyperkalemia, hypokalemia as well. All right, so then what else? No lethal rhythms. Sorry, so basically EKG format is going to be there's a strip, right? You have to interpret. If it says your patient has this EKG and it's AFib, and it gives you a picture of AFib, that's a knowledge-based question, right? That's just like I didn't have to use your brain to critically think, what is this, or interpret it, right? When you're interpreting lab values or interpreting an EKG strip, that's a higher level critical thinking question, right? And how many questions are like that? 75%, right? So that's why you have to be able to interpret lab values, interpret symptoms, interpret if this are the right instructions or not for a patient, right? With this disease process, right? Is it right to tell someone with GERD not to drink lemon juice? It's like, no, that's fine. They can drink carbonated beverages as long as it's not like caffeine, right? So that's really more for LNF, for laparoscopic Nissen, right? To avoid bubbles, right? So it's kind of is the right teaching. Or someone like to eat small frequent meals. Is that good for GERD? You could argue it could be, because if they have huge meals, it can make their sphincter, you can push open the sphincter and cause more. But usually the small frequent meals was for like dumping syndrome, right? Or for for LNF, right? So that's the idea with critical thinking level questions. Okay. But yeah, so it's, the strip you have to interpret, right? This is analysis and critical thinking, right? Okay, and then you have to think, what is the teaching? What is the intervention? Right? And what is the treatment? What is the cause? Right? So for like bradycardias, what are the causes of bradycardias? Those are the treatments of ABCD. Causes for a Mhm. Yeah, so it's dye, right? So it's drugs, right? All right, so including your ABC, I think was that what you're saying, ABCD drugs? I think I cut you off too soon. So it's, yeah, so ABCD drugs are, yeah, can lead to bradycardia, right? All right, so drugs, I for ischemia, right? And then there's E for electrolytes, right? And then there's like normal stuff, right? So age, right? What else? There's the S. It's okay if it's 42 or higher, but if it's not, if it's less than 42, it's a problem.
Oh, sleeping.
Sleeping, right? Age, sleeping, and athlete, right? Those are normal variants for bradycardias, okay? But otherwise, die is your worrisome ones, right? Does that make sense? So basically, you have some bradycardia in front of you, right? And what are you gonna do next, right? Mhm. Yeah, so the treatment is, it's basically if symptomatic, right? That's the first step, right? Especially especially like sinus bradycardias. If they have like an idioventricular block or a junctional block, they're usually symptomatic. There's usually something going on. It's not something you can just like like, oh, they just got junctional blocks, let's let it ride. Okay, so that's the idea. So what I'm doing here is kind of like a study guide, and there is a study guide. I don't know if I put it in here or not. I linked to it at least.
You put cholinergic, just not.
Mm-hmm. So you upload your study stuff here. So study session, EKG study session. Where's it at here? So I can download it and then upload it as well. So let's look for like what students did last semester, and that's something we can upload as well if you guys want. So let me just kind of find it. So lecture transcripts, nope, I want last semester's. Exam 1 study tools. I linked to this. It's not something like I was keep holding secret, I promise. Student version, this looks like it. So let's make a copy. And let's then move this over to the other one. Move to share. Nope. Organize. Move. And let's move it over to the new one. So 2024. Let's go over there. Let's do exam 1 prep. Let's move that there.
But nobody can make changes to that, right?
I can make it so no one makes changes to it. So that way it's pristine. And then you can add to it if need be. So I lost it. So let's go back up here, exam lectures. Oh, back one.
Do you recycle any of your questions for the final?
The final is usually questions that weren't asked before, right? Or if it's important things, I would ask them again. But for instance, like if we didn't get a lot of ulcerative colitis questions, for some reason for GI, we'd have the ulcerative colitis questions back over in the final. Yeah, again, that's what this time's for. Go ahead and make so let's rename this. Student version 2024. Okay. So it's kind of, we've done this, I did this with the group last year, so they have we just went through it, right? So EKGs and sinus rhythms, we just went down from memory, we're trying to add things in, right? What the treatments are, and then I'm not sure if we got to everything, like I think we gave up on EKGs because like we already did this, right? But ventricular rhythms we were talking about, right? So this is not complete, but we can make it complete if you want, right? And bradycardias, I think we talked about that. AV blocks, junctional. So they're like, we need to talk a lot more about pacers, right? So that's the idea with pacers there. Okay. I have to make sure this, because there can be mistakes. I just have to make sure the wording is correct. Okay. So I can review that, right? So general things you do for patients, right? If they have a pulse, it's just ABCs, right? So your airway, breathing, circulation, what's your blood pressure, right? So that's BP, right? So that's kind of the key because that's going to tell you what's, whether we need to shock them or we need to, monitor and try to fix the underlying cause, right? Right? If there's no pulse, then it's CABs, right? You're doing a CPR and you may or may not shock them depending on whether it's a PA systole or not PA systole. Okay. And of course, code button is probably important too, right? So tachycardias, so we talked about the causes of those, and then cardio version a little bit about that, right? H's and T's, some IV push stuff. So that's the idea. So then we have GI tubes, and then we had organs and rocks and such. Okay, so that's the idea. So that's there for you, and we can expand on some of these things too on one of these sections. All right, so does that make sense for EKG test questions, how they look, right? So they're going to be an EKG there, and then you have to figure it out, right? What EKG is it, and what do I do with it, right? So like, for instance, let's grab a random EKG here. Let's go to, I think under images. EKGs, yep. All right, so don't look yet. So I'm going to turn your head. I'm going to double click an image. So let's go to this one. All right, so what is that? So it's a wide QRS, right? And we have a no P's. So it's really spelling out idioventricular, right? So it's idioventricular rhythm. So then the next step is, the question could ask one of three things, right? Symptoms, it could ask symptoms, causes, treatments, right? The interventions we know are the same for every EKG. So you could ask that too. So there's four possible questions for this. And if you made your chart, you know all the possible questions, right? That's going to ask one of those four things in one of those four boxes, right? Under junctional. So it's either going to ask this question. It could be one of those, for what are the causes, for instance, right? And that's DIE, right? It's usually not age, yes, could cause this. They're probably coming to the hospital for this, right? But usually this is not someone sleeping. This is not someone that's an athlete, right? This is something's wrong, okay? So it could be ask you, well, the nurse knows what the causes might be, select all that apply. Or it could be just a simple multiple choice question where you have to select the correct answer, right? Is it methamphetamines or is it excessive, digoxin use, or is it, I don't know, is it excessive metoclopramide use, right? Metoclopramide like, no, the QTC is, it's prolonged, but is that really what's causing it to be like this? I try to make sure it's not something you could maybe not argue, but something that's something clear cut, right? So like pantoprazole, it's like, well, yeah, my pantoprazole can lower your MAG and make you make your electrolytes super low, and that could cause this. But we said electrolytes would be high electrolytes, right? So we don't want you to. It's usually not something that's like second level, third level, fourth level removed that could make it the right answer. It's usually a clear cut answer, right? If you ask those I've taken my class before, it's usually they're fair questions, right? You either missed it or you didn't. It's not something that's very, very nebulous. And if it is very confusing or very out there and very gray, then usually I say, oh yeah, you're right. That's then I'll throw out the question, right? I'll say that's not a fair question. You're right, right? But if it's fair and like 85% of the students got it right, I'm probably not throwing it out, right? But if only like 20% or less got it right, and it's like it was my fault, that's not an assessment of your learning, right? If it's my fault, all right? So that's on me. So that question would then get dropped. Okay. So yes, there's idioventricular rhythm, right? So then we have, the question can be go four ways. What are the causes, right? It can be any one of those causes. What are the treatments? How do you fix this? You can either just pull it out of your brain, all right, out of your gray matter, or you can kind of picture your table in your mind. It's like, what do I do? Oh, Pacers, those are blue. What was that blue section, right? It's like, oh, Pacers, shoot, right? So I blocked out Pacers because it's so hard, right? But Pacers are something that you would be doing for bradycardias, right? It's usually a more advanced therapy. We have other things we can do ahead of time, right? We can give medications to see if we can maybe get them out of this, but really medications are not going to work on junctional or idioventricular rhythms or high degree blocks. Usually pacers is kind of where it's at for idioventricular rhythms. Okay. So yeah, so they're gonna, if they have no pulse with this rhythm, what is that now? It's not idioventricular anymore. What is it called? PEA, right? It's pulseless electrical activities. There's electrical activity there, but it's pulseless. Okay. So yeah, you have to look at the question too. And usually I'll write down on the strip, it's pulseless, right? Or in the question, I'll say the patient has no pulse with this rhythm. Okay, so now you're gonna switch gears. Like, oh no, let's set up for a pacemaker. Let's set up for a transcutaneous, transvenous, permanent pacemaker. We're gonna steer clear of high wave 5G towers, right? That's not the priority at this point. The priority at this point is to get them paced not paced, I should say, backtrack, not to get them paced, but to get them, do CPR if they have PEA, right? CPR and epi. Okay, so that's the idea with these test questions, right? Does that make sense for test questions at EKG? That's how they're formulated, right? So you have a strip that you have to interpret, and then you have to know what to do with it, right? So in your study sessions or your study groups, that's what you want to do. It's like just pull up an EKG and try to stump your group. Don't do something super weird. Just something that's clearly AFib, clearly PSVT, clearly junctional tach, clearly VTach or VFib. And what do you do with this? What are we doing, right? And you can run through all four scenarios. I'm going to do CAB, not ABCs, or I'm going to get an EKG and blood pressure, or I'm going to, I'm going to give atropine, or I'm going to give epinephrine, or I'm going to give amiodarone, right? So these are, or even adenosine for PSVT. So that's the idea behind EKG questions, right? Does that make sense? All right, so that's EKG questions. Do you want more EKG questions, or is that good? All right, so strip you have to interpret, and then you have to figure out what it is, right? And again, this is based off your table here. So if we did junctional as example, right? So if we have our junctional rhythms here, do you even do junctional? No, when we did bradycardias. I thought there was a section for bradycardias. All right.
We did add,
So we should, we need a bradycardia section. That way you know that it could be any one of these questions, right? That's the idea. Does that make sense? So it's not going to be a question that says AFib is known as irregular or regular, right? Or with P waves, without P waves, or with fib waves, and select all that apply, right? So fib waves and irregular. Yes, I got it right. Right. That's a knowledge-based question. If there is, that's would be a knowledge-based question, right? Like an AV block, for instance. AV block has what characteristics? Select all that apply. So you'd say what? Well, let's pick a random one. Pick a random AV block. Second degree type 2, right? So second degree type 2 AV blocks have what features? Select all that apply. So it's irregular rhythm. What else? Drop QRSs and prolonged PR interval most of the time, right? I may or may not put that because that is, it's like, well, but it could be, sometimes sometimes it's normal, right? But like secondary type, then I'll probably change it to secondary type 1 because that's definitively PR interval. I would say PR interval gets longer, right? Or PR interval is the same. So you say, no, that's wrong because I know the PR interval gets longer. Okay. So that's like a knowledge-based question. Let's put an example here of knowledge-based question.
There be any knowledge-based questions?
Yeah, about 25%. Okay, so that's like, patient has, that's what we just said, secondary type 1, right? AV block, no strip to interpret, right? And SATA, and you would say that it has longer, right? Irregular rhythm, drop QRS. You would select those as the correct answers. Okay. All right, so moving on to interventions. Is that what you want to go next? We have study guide all the way down here for learn. So what do you want to do next? Interventions. Okay, so again, interventions are going to be, if this, I don't explicitly state interventions on the slides that where it's kind of assumed, right? So you're going, if someone has symptoms of abdominal pain and what is it, some GI bleeding and what else? They have burning sensation in their under the subxiphoid. That's looking like GERD, right? So that's going to be the nurse interventions would be to look out for GI bleeding, look out for burning sensation in X, Y, and Z. That's kind of the intervention, right? So was another example, like Crohn's disease, for instance, right? So they are malnourished. We know they're malnourished, right? So the intervention is watch out for being malnourished. Make sure you encourage high B12 and folate foods, right? That's kind of the thing. They're malnourished and they're B12 deficient and folate deficient and iron deficient. So the interventions are to increase iron, increase folate, and increase B12, right? That's kind of, they go hand in hand. So sometimes I don't explicitly say that, but that should make sense, right? That's what we're going to do. Same thing for treatments is take your medications. There's not a disease process where it says don't take your meds, right? So our purpose, we want to make sure they're compliant with their medications, right? But when in the slides, when I explicitly say make sure you teach these things, those are good questions that could be SATA questions, right? So like for teaching, right? So you have teaching for like LNF, right? You have teaching for like dumping syndrome. You have teaching for what else? What else comes to mind that we talked about last week? Yeah, hiatal hernia teaching, right? Hiatal hernia GERD, right? There's two things. There's like sleeping, right? And there's LES teaching, right? That's like 4 easy SATA questions right there, right? Let's just highlight what questions would be. Let's go make these nice and highlighted. Sure, orange on white. Okay, perfect. Right, so yeah, so these are easy SATA questions, right, that you would be looking for. All right, so EKG format questions, so example knowledge-based question, we talked about that as a sample question. Let's make that orange. That one highlights, the other one orangifies it. Okay, so what else we talked about? No lethal rhythms, that's for sure going to be a test question. Keep doing it backwards, sorry. All right, and then CPR epi for lethal rhythms. What else we talked about? GI, know these ones, right? And when I say no, what do you need to know for all medications? So you know the cause, so indications, right? This is for any medication ever, right? So we talked about like any disease process ever, you have to know certain things. For any medication, you have to know those things. For interventions, you have to know things like EKGs, for instance. EKGs, you have to know what the indication is, what is it for, right? You have to know what the complications are of that process. And then you have to know pretty much interventions. What's the prep, right? They have to be like they have to be MPO and get a bowel prep for colonoscopy, right? They need a consent and you give sedation as well, right? Anyways, for indications for meds, what else to know? You have to know their MOA, the mechanism of action, how they work, right? And that's really going to get you your side effects, right? Do I emphasize mechanism of action 100%? That'd be like a knowledge-based question, right? How does pantoprazole work? Oh, it's a proton pump inhibitor. Bam, got it, right? So but that doesn't. It's like, so I don't know about you, I have to quickly think that, right? But that is a more of a knowledge-based question, but really that's going to get you to the side effects, right? It should get you the side effects most of the time. Where for cardiac meds, it's really, really clear cut. It's like, oh, it blocks beta receptors, therefore I get bradycardia. That's how it works. It's a mechanism of action, right? Pantoprazole, it's a little bit more loose, right? It's reducing gastric acid, right? And you can kind of get to the side effects where now I have stuff that can proliferate because I have less gastric acid, such as what stuff? When I have a gastric acid that is less, right, with like pantoprazole, for instance, and famotidine. Good, all right, H. pylori and C. diff, or CDAD is the C. diff associated diarrhea, right? All right, so you know side effects and then interventions, things that weren't discussed previously, right? So of course, monitor for H. pylori, monitor for GERD, monitor for H. pylori's side effects, which is GI bleeding, monitor for GI bleeding. And we know that it can also lower MAG, right? So monitor for low MAG, right? It can also interrupt B12 stuff, so it can monitor for B12 deficiency anemia. But really, I'm not going to test you on B12 deficiency anemia for this test because we're going to learn about anemias properly. And that's where we're going to learn all about B12s. But for the final, it's fair game, right? Because now you're putting everything together. Okay. So that's the idea with, we're trying to focus on one specific thing. Okay. So I know, and again, I shouldn't have to explicitly say monitor for the side effects, right? We're going to have things that are unique about it, right? Like pantoprazole therapy, you usually don't continue more than 8 to 12 weeks, right? Otherwise, you're high risk now for a CDAD and H. pylori. It's usually like 3 months tops. That's usually how much you get for PPIs because they're so super strong, right? And you can put that on nurse interventions or that it's the strongest acid reducing agent, right? Whereas like H2RAs, famotidine, they're weaker, right? They can be on that for a long period of time, but it has the same kind of side effects. Same risk, but especially if they're on for longer. All right, so you know those ones, and of course, you want to know your EKG meds. All right, which one they're attached to, and that kind of goes hand in hand with what we said below, that they have here's a strip, what do I do about it, right? Treatment is atropine, right? So you're selecting from the list, atropine or adenosine. Which one they do have, they sound similar, but they have completely different actions, right? One raises the heart rate, one lowers the heart rate. And the same thing, atropine, amlodipine, right? Adenosine, amiodarone, which one are you going to give for bradycardia? Atropine, right? So you want to be able to differentiate that. Okay. If it just say, what do you give for bradycardia? That's a knowledge-based question. If it has you interpret something, that is a critical thinking level question. Okay. All right, does that make sense? So that's kind of the teachings, right? That's what interventions are, right? Yes, it could be monitor for this, monitor for that, monitor for this complication, monitor for that complication. But specifically, these are when I've spelled it out, it's probably going to be tested on and likely to be a SATA question or a next gen question, right? Because there's like fishbone, or what is it? Not fishbone. What did I say? The bow tie questions, right? Where I say this causes this disease process, right? There's 2 options that cause it, and there's 2 options you monitor for. So I'm going to monitor for bleeding, and I'm going to teach about dumping syndrome, for instance, right? That'd be something I would teach to someone with like post LNF, right? Versus post guest. I don't know. Try to think of something that else we differentiate. I don't know, like we'll learn about TIPS syndrome next week, right? TIPS syndrome, you're not going to teach about how, like sleeping hygiene and such, or TIPS procedure. All right, so then complications. So these are things you're monitoring for, right? So you're monitoring for alarm symptoms, especially for our GI tubes, right? Your monitor for all of them had cancer as a risk factor, as an end complication. So you're going to monitor for colon cancer, monitor for alarm symptoms, unintentional weight loss. They have, they have melena or hematochezia, right? They have coffee ground emesis. They have dysphagia or a palpable mass. Right? These are all cancer symptoms, right? So there's things you're going to monitor for, right? When someone has a disease process, it's important to worry about the worst case scenario, right? So it's, oh, I got this burning sensation underneath my sternum, and it's like then they say, oh, also I've been having dark tarry stools. It's like, well, shoot, you got to get seen, right? That's a problem, right? Or I've lost 20 pounds in the last 6 months. And are you exercising? What are you doing? Like, no, I did nothing, right? I've been in nursing school. It's like, well, shoot, that's a problem. Okay, that makes sense as far as what interventions would be. Okay, and those, yes, those are tested on. So what am I going to teach for? What are the complications? What are things that make me concerned? Okay, and that is, again, interpretation of the information, right? So you have a case study or you have a quick little scenario in front of you, a little stem, and say they have this, this, and this, and they have X, Y, and Z. That's what are you concerned about, right? I'm concerned about esophageal cancer, or concerned about colon cancer. I'm concerned about GI bleeding because you spelled out they have peptic ulcer disease, but all of a sudden you said they have hematemesis. That's not a normal finding for someone with ulcer disease, right? They can have burning sensation after they eat, right? But once they start having GI bleeding symptoms, that's a problem. Okay. All right, does that make sense as far as interventions? All right, so disease processes. All right, so what do we say about this? Diagnostic tests and symptoms. What are we talking about with this one? I forgot. What we're gonna do with this?
Well, to focus on what you want to know for a specific, like, a disease, what you really want us to focus to know what tests to do for them.
Mm-hmm.
That's what we're
Yeah, so every disease process has, the causes, the symptoms, and sometimes it's diagnostic tests, kind of combine them sometimes, but sometimes some disease processes have a lot of diagnostic tests, right? So it might be better to separate it out. Like when we talk about gallbladder stuff and pancreas stuff this week, there's like 5 diagnostic tests and there's like 5 symptoms. So I'd like to have 2 columns for that, right? I don't want to like mix and match them. My table might get my column might get super long. Right, doesn't look neat, doesn't fit on the page. It's like it's scratching my OCD. So I like to have another column for that one, right? But for like when we talk about the tube stuff, really just like monitor H&H, right? Because and maybe it might have like a fit test and a colonoscopy and EGD. Those were kind of the only other diagnostic tests we had, right? And ironically, some of those things were, like colonoscopy and EGD, they could actually be a treatment too, right? They had kind of double duty. All right, so diagnostic tests, complications, and then interventions, right? So that's what you want to know for every disease process, and then what am I going to do about it, right? So what do you need to know for these? I mean, usually your goal is at least 3. Goal, at least 3, right? That's kind of your baseline, and then you can like sprinkle in a few other ones, like, oh yeah, that one really had a lot more stuff going on with it, right? So that means you should know 3 causes, you should know 3 symptoms, 3 diagnostic tests, 3 complications, and 3 interventions. Sometimes there's not 3 complications, right? Then you got 1 in the bank, then you maybe might have more diagnostic tests or more causes, right? Like there's a lot of causes. Well, there's like 3 causes for like hernias, for instance, right? It's increased intra-abdominal pressure or weak muscles, or they had a like a surgery of some sort, right? Right? They have like weak collagen, like they had smoking, like you said, or they had steroid use, or they're getting older in age. Okay, so you want to kind of 3 things for each, right? That's kind of your goal, and it's what you want to be able to teach to your study group, right? So you should be able to just go to the whiteboard, like, oh, we're talking about hemorrhoids now. All right, let's go, let's do it, right? So what are the causes? So you might draw blanks, and you might forget about one, right? And then you're like, oh yeah, that one. And you want to forget it during your study group. You don't want to forget it during the exam, right? If you don't have study groups because you don't have friends, that's fine, right? You can buy a shower curtain at Walmart for 97 cents. You can hang it up, and dry erase markers were perfect on a shower curtain, right? Or you go to Home Depot, I think it's like $5 for this white vinyl, and that works for dry erase as well. Or you can go to Staples and spend $200 for an actual dry erase board. Yeah, for an actual dry erase board, right? But you know, there's options to teach it out. Or you just get a blank piece of paper and you just write, go hemorrhoids, bam, I'm writing the whole thing out right now.
The sleeves, that works as like a.
Yeah, you get a sleeves as well. And you have a blank piece of paper inside, or you have like a table inside. Okay. And then of course you can even print your notes and like delete the table information, but then have the box height and colors, right? That way you know that, oh, this is the blue one, my bradycardias, and this one had a lot in it. So this, because it's Pacers, it has all this stuff. I can't remember, I make sure I forget this one, or this one's like super narrow. That was an easy one, right? Does that make sense as far as how to learn the information, right? You want to be able to, you know, A, get the theory in your brain, but then B, you're going to get you're developing all your notes and study tools and everything. And then the most important part, about 75% of your studying should be just teaching, right? And learning the material, right? Because the material is not going to change, right? Like when we learn about gallbladder stuff has not changed in 75 years, right? The symptoms of gallbladder are still the symptoms of gallbladder, right? The diagnostic test for gallbladder, there's new stuff around, right? But the cholecystectomies for taking gallbladders out, that's been the treatment that's been around for almost 100 years, right? That's not going to change. So you should be able to, when you're teaching it, like, oh yeah, cholecystectomy, that you're remembering that every single time. Okay, so that should be how you're doing your study sessions. They should be, 60% or more should be just learning and teaching to each other, right? Don't just be reading your notes to each other. That doesn't help, right? That's called a study group. That's called a book club, right? So it needs to be active learning, right? And you will bounce around with study groups, like, that was nice. Thank you for your time. I'm gonna find another study group, right? And you can just go to someone, hey, you want a study group tonight? It's like, you're already another study group, right? All right, does that make sense for diagnostic tests and what that means, or what you need to know for them? You talk about EGDs. EGDs are for the GI world. That is kind of the bread and butter, right? EGDs are going to be used for a lot of them. Right, it's used for GERD, hiatal hernia. It's used for a peptic ulcer disease. It's for all three, right? So if you learn it once, then you just copy and paste it for each one. And you can make a quick table. Like for EKGs, we did something for like pacers down here, right? So you can make a quick table for GI procedures. Right, we've got EGDs and colonoscopies, right? And you can kind of think about other things, maybe like a barium swallow or esophageal manometry, right? So but the big ones are EGD and colonoscopy. It's like, and then you have to know what to do about it, right? So know what it's indicated for, and then there you basically for EGD you had your hiatal hernia, you had your PUD, you had your esophageal cancer, for instance, gastric cancer. All those things are indications, right? So then obviously it's like a Wikipedia article, you click on one of those, it should bring you back up to the disease process. And the disease process, you should see EGD there, right? So that way you've kind of encapsulated EGD and what you do about it. And it also should have, consent and prep and all the other fun stuff. That way, every single time someone says EGD, that's what it means. Okay. All right, what else? So surgical treatments for GI. Do you want to talk about these ones? All right, so what was your specific question here? What do you, how to differentiate them or what? Good, so gastrectomy. So again, I would make a quick chart, all right? So I'd say, what are the indications for this? All right, what are the indications? What are the, what are those, what's the procedure itself? Procedure steps. But you're not becoming a surgeon. So you can just put a picture, right? So that you can know it's like, oh, that's that one. That's where they took out a piece of the gastrum, right? You don't even know that they're going to ligate the superior or the lower esophageal epiphyseal artery, and they're going to ligate that, and they're going to cut through the ligament detritus, and they're going to do this and this and this. You're not being surgeons right now, right? Your book might describe it in detail. That's perfectly fine. But all you got to know is like they're taking a piece of your stomach, right? You got to know which one's which, right? Which one takes out the head of the pancreas? Which one takes out puts a shunt in the liver when we talk about tips next week, right? And we talk about Whipple procedures for the head of the pancreas. But for like gastrectomy, you're taking out a piece of the gastrum, right? Or they might do a Roux-en-Y, right? Or Roux-en-Y, how do you spell Roux and Y? Okay, that's usually what the indications are. What's the indications for you for gastrectomy or Roux-en-Y? Hey, what?
What, like
Mhm.
peptic ulcer.
It's usually gastric cancer, right? It could be, yes, it could also be due to a bleeding ulcer. severe bleeding ulcer.
What about from?
Which is a perforated ulcer. Crohn's is, yes, Crohn's can affect all the way from the mouth down, but it's most commonly in the ileum and the proximal colon, right? So, I mean, could it affect the gastrum where you need to have a resection? Rarely, right? That's not something I'm going to test you on. I'm saying, oh, it could be Crohn's. 'Cause remember I said Crohn's affects the whole GI tract. Isn't the stomach part of the GI tract? I'm not trying to trick you, right? Yeah, there's no reason to trick you. That doesn't, what does that do for you? And what does that do for me to test that that you know it or not, right? So my goal is to make sure that you know it and that I've assessed that you know it or not. Okay, and I'm gonna assess you on the most common things, right? I'm not gonna assess you on random little tiny factoids, right? And it's definitely not statistics. Okay, so yeah, so indications, procedure steps, I just like snap a quick picture of it, right? And then what else do you know about procedures? Complications, maybe, not so much. That's more like GIs. I mean, I guess when we talk about like TERP, for instance, when we're talking about male GU, but really I didn't give you many complications, right? Complications could be like it's kind of more like teaching. So like make sure you come back if you see like they've got a fever because the wound can be dehisced, right? Or they could be developing an abscess. That's kind of nurse interventions kind of tied into one. Good. All right, so gastric cancer. So for instance, indications, and we can go to our study guide and just add this to it, all right? So indications, gastric cancer, perforated ulcers, right? Procedure, right? We're just gonna snap a pic. Okay, and then for complications, that's kind of overlap with nursing, right? So you just like put what it is, and then nurse intervention can do, what's the teaching, right? So what's the teaching, right? So complications, so you can put like dumping syndrome. I'm not gonna list all the things I'm gonna do for dumping syndrome. I could put maybe the symptoms there, and then I'll have like the teaching, right? Teaching for dumping. That makes sense? So that's a quick table for gastrectomy, right? Same thing for LNF. What's the LNF teaching, right? LNF teaching is not small meals, yeah, but it's not like definitely dumping syndrome. You need small frequent meals, right? You need small meals, not high glucose meals for sure, right? We want low carb meals for gastrectomy. For LNF, low carb meals, why? That doesn't do anything, right? For esophagectomy, you're borderline, you might take out a portion of the gastrum too. So it's a similar situation. Dumping also, right? And there's like, you could put like up the top general surgery stuff, and this is what you learned in theoretically fundamentals, right? In fundamentals, you learned post-surgical complications, right? So that's just general things you learned, right? It's the 5 Ws. What are they? That's one of the W's, wound, right? So there's like wind in the first 2 days, right? There's walking. They need to walk, otherwise they get a DVT, right? There's what else? There's water. They get fluid overload, right? Let's get too much fluid, such. Okay, so there's just the general complications for surgeries, right? And general things. I'm gonna monitor the wound, make sure it doesn't get dehisced, right? So those are tested on in fundamentals. That's not something we're gonna test you on here, right? Unless it's like a common thing, like it really this like really has a lot of wound problems, right? Usually it's probably not good surgery if it causes a lot of wound problems. Okay. All right, so tables. So we've talked about tables and study guides we can kind of combine together, right? So if we do a study guide here, okay, so for instance, let's take one of these guys. So I kind of made one here for, what is this? Hepatitis. It's all liver stuff. Let's go to our Nissan or Nissan or funduplication. Oh, good. We haven't made one yet. So let's make a funduplication table. And that would be under GI tubes, right? So general stuff, teaching and such, like dumping syndrome, esophageal cancer and such. So you can make a quick table, right? So insert table. Let's make it 5 wide. Okay, so you're saying indications, you can say procedure, We say complications and interventions, right? And then what do I do for each, right? So we said, what was our first one? Esophagectomy, right? And they have gastrectomy. You could put Roux-en-Y here. You say ditto, right? Because we said this stuff for gastrectomy. And then we had L and F, right? Or Nissan. Okay, so L and F was for what? All right, so hiatal hernia, right? So hiatal hernia is the indication for it. Are there other indications? Yeah, you could say, you could argue GERD might be if they have really, really severe GERD and their LES is very, very weak, right? So GERD too. Okay, what's the procedure, right? So they tighten it up. Right, you just throw, yeah, you just throw a picture on there too. So L and F.
Would that make them like long-term,
Lure nanofabrication facility.
would that make them, cause I'm assuming it takes a portion of the stomach, right? Would that make them lose weight? Too, kind of like,
It's not that much of the stomach
Oh.
that they would lose weight. That's, I want a better picture. It's, there it goes. That looks nice. Mhm. Okay, and then complications, right? So complications are what? It's really just standard, right? They could have bleeding, right? You're gonna watch out for GI bleed. Or that could mean that the sutures didn't stick or they punctured a vessel or something, right? So that could be GI bleed as complication, but interventions, there's specific interventions we're gonna do for these guys, right? So no what? No heavy lifting,
soft foods, is it this one? I don't know.
soft foods, I mean, it's really for all of them, soft foods. No straws, right? No bubbles, right? And then you can say what that entails. Acids, right? So citric, tomato, what's the other one? Acetic or different acids, right? That's kind of citric, but I'm trying to think of. Anyways, so that's the idea. You're adding all the things in there, right? But what is on the list? So we can make this somewhat complete. What else is on the slide? What else we would add to the
Table.
to our L and F
Oh.
for teaching? Good, no chewing gum. So no bubbles. Let's put no air. So the sleeping in 2 hours thing, that's the same teaching you would do for all the GI, all the LES issues, hiatal hernia and GERD and such. But what is like specific to L and F? Anything else? That's for sleep on the left side is for hiatal hernia and GERD, just in general. It's like what's specific to L and F. But it's not wrong, right? Tell this to a patient, it's like it would not be wrong to say that. It's kind of the same thing. So like GI, report, GI bleed, report any wound, abscess or infection or fever or such, right?
You also, excessive, satiety, you put as a, like to report if they
Good.
get full fast.
So it's excessive satiety. So we can put on report. No tight clothing, right? You can put the reason why too. So like they're, they might have cinched off too much of the stomach, for instance.
Vinegar, so citrus, vinegar, and tomatoes.
So vinegar is that acetic acid? What should I think of? Oops, I hit Alt D. All right, vinegar. Yeah, it's acetic acid, right? Yeah, so yeah, acetic acid was our vinegar. Citric, acetic, which is vinegar, and tomatoes. Okay. And then of course we talked about some of the things here for esophagectomy and gastrectomy on this guy here, right? Talked about dumping syndrome, right? Gastric cancer, perforated ulcers would be something we'd add over there. So we can fill this out some more.
Someone wrote it down. Check.
All right, I'll look real quick. Okay. Report dysphagia to excessive society, report dysphagia. That's telling you that it's too tight. Okay, it might be swelling from the post-procedure, inflammation and such. All right, so we can fill this out some more. So procedures. That's the idea. All right, so it's a quick break so I can plug in the computer and then we'll go over what else you want to go over. So think about some other things you want to add to the agenda, or if you're done for today, that's fine too. All right, he's like, no, I'm tapped out, right? So tables, study guides. So we're kind of over here. And we can go over certain topics in the study guide. Like, no, I definitely need to go over this again. And we can look at that section and we can flesh it out. Okay. Or we can do things on the whiteboard where you're actually, we're drawing stuff. Okay.
Why do they make our semesters only 8 people? Like it's so.
All right. So we're going to, part 2, we're going to do tables and otherwise known as static questions, right? These are, they could be static questions. They could be next gen questions because next gen questions are just static questions with extra steps. That's all they are, right? Where it says like highlight in the nursing notes what is appropriate for GERD, right? So you're just basically highlighting 3 to 5 things, right? And the new next gen questions ask you it could be like 8 options, and it says select 4 or select 2 or select 6, right? To find, and I figure those are easier actually because you're selecting, you know which 4 or you know which 6 or know which 3, as long as they give you the right answer, right amount, right? Yeah, partial credit is applied, yes. Okay, so these are things that we're going to talk about real quick. So for Zoomland, well, let's have Zoomland since they can't participate in person. Pick first. Which one do you guys want to do? Well, I give you 2 actually. I give you IBD, colostomy, ileostomy. Is there something else you guys want to compare and contrast? That's a good one. So diverticulitis versus diverticulosis. The dilotis.
I was thinking about them backwards, but after watching your lecture, it makes, I guess, sense, because diverticulosis is the one that causes bleeding. But diverticulitis causes the peritonitis. I thought for some reason diverticulitis caused the bleeding.
All right, so yeah, so we'll do diverticulitis in person, right? And we could do Crohn's and ulcerative colitis as a group, but if you guys want to take a crack at it, and then we'll add to it. Does that make sense, right? So for those of you guys on Zoom, let's make it organized. Let's make a table here, and we'll just copy and paste it afterwards. Does that make sense? So you guys have access to this study session 2 file. I'll put it in the chat so you have a direct link to it. It's in the exam 1 folder, but let me share it so it's easy for you to click on. So share with others. Make sure you can be a editor, so you can edit this as well, because your drawing might be jank. Let's go to this one here. Let's just go down here. We'll make another page. You're making, let's put a table. And we're doing this in person as well. So table 5 by 2, 5 by 3, because we want to know what is the same for both. The page setup is wonky. I thought I changed this page setup. Maybe it was for a different file. Let's make it landscape so it looks nice. Perfect. And let's fit this again. Fit. Perfect, right? So for those, so we'll come back to this IBD table, but in person we'll do a diverticulitis deal, and we'll draw this on the whiteboard, and we'll then assemble it here, right? So we got all IBD, right? And we then have, let's do it backwards. Let's do ulcerative colitis first this time. In the lecture we gave you Crohn's first. We'll just kind of switch it up so you're thinking forwards and backwards, right? And then Crohn's disease. So you're looking for causes right here. You're looking for symptoms. And let's just put diagnostic tests, the same deal. We need to add a column, forgot a column. Diagnostic tests, we got treatments, and then we want columns, insert a column. right? So we got complications, right? Because we know both of them have what complication?
Bleeding?
Colon cancer. Symptoms, yeah, they both have diarrhea, right? This is one's more bloodier than the other, right? So then complications and then nurse intervention, something specific that wasn't covered elsewhere. If that makes sense, right? Of course, you're going to monitor for colon cancer. You're going to have them do a colonoscopy at age 45 or even sooner. You're going to have them do a fit test every year. That's kind of in here, right? And then colon cancer should be its own little deal as well. So you copy and paste whatever you know about colon cancer here. We're not going to put all of colon cancer in one little box, right? Try to separate out and make it as even as possible. All right, so you guys should have access to this. I did not share it with you just yet. Let's put it in the chat here. Chat, so you guys can, that didn't work. Let's go back to this one. All right, so you should be able to click on that and then start editing this. Does that make sense? And then we'll come back with what we did on the whiteboard, that where we're doing some tactile stuff. And we will be doing our all diverticuli. So we'll do this in person, right? In person, all diverticuli, and then diverticulosis, and then diverticulitis, right? And we'll fill this out. So you guys online will fill out the top one, and then in person we'll fill this one, and then we'll fill it in as well. Okay, nice Zoom peeps. All right, so let's get some blood flowing in our legs, lower our DVT risk. All diverticuli, right? So it's caused by, what did we just say here? It says straining, right? There's straining, there's abdominal pressure, and there's weakening, right? And weakening, you could say what? Age, smoking, steroids, right? Steroids break down collagen, right? What else? Abdominal pressure, we said. Obesity. Heavy lifting. Anything else? What is that? Tight clothing. And then straining is due to constipation, right? Which is low fiber, right? Okay. All right, that's it, right? Yeah, it can be low fiber, low fluids. Okay, and then diverticulosis, right? See above. And then diverticulitis, the cause is diverticulosis, right? But it's really a infection has taken hold. To poop rock, right? Fecal death. All right, so then what else? So symptoms for diverticulosis is asymptomatic, right? Good, so left lower quadrant pain, right? And infection, that makes sense. I get a fever, SNS symptoms, right? And this is called SIRS. We'll talk about SIRS on the for the next exam, okay? And then what else? Treatments. Diverticulitis, you're giving antibiotics, right? Okay, and complications of diverticulitis. Perforation, fistulas. You can put abscesses separately, but it's due to fistulas, right? And fistulas, you have 3 varieties, right? Or 3 to 4.
Because the poop is going into like our tissues and it's causing
Mhm.
infection.
Yeah, it's perforated through, yeah. Right, but it hasn't like perforated to the bowel or the bowel space, the intraperitoneal space. It's just gone local, right? So fistulas, right? Colo. Okay, and then we have perforation, which leads to what? The fancy arrow though, that leads to peritonitis, right? Which was your or like abdomen, diffuse abdominal pain. Some SIRS too. All right, and then interventions.
No
So
problem.
what you have, right, diverticulosis, so were there,
Mm-hmm.
no enemas,
Fix yourself.
All right, so colostomy, what else?
nothing else, so,
No,
but.
colon.
Mm-hmm. Right.
That's what you meant to put
Colonoscopy,
instead of
right?
colostomy.
So yeah, you're right, colonoscopy. Okay, enemas, right? Fix yourself.
So, boo.
Mm-hmm.
Okay.
No fingers up in there.
All right, so then diverticulosis, asymptomatic until it's not. What's a complication about diverticulosis? Yeah, so lower GI bleeding, right? So you should have a table already for GI bleeds, right? So upper versus lower versus all, right? So all GI bleeds have low H and H's. Doesn't matter where it's coming from, right? But like what's specifically upper, what's specifically lower, right? Like you add a column for new versus old, right? So new bleeds have hemato in front of it, and old bleeds have something else. They have melena or they have coffee ground, right? So does this person have coffee ground emesis? No, that's really, really hard to vomit blood from your anus, right? From your sigmoid colon. It's like, no, right? That's not possible, right? So it's lower GI bleed, right? So they can have hematochezia, right? Or maroon stools, right? Which is hematochezia. Let's put that in parentheses. Let's put this one, bright red blood per rectum, right? Bright red blood per rectum. Maroon is a little slower, but it's sometimes maroon. Right? Or they have what? If it's a slow bleed, I mean, it's right there in the sigmoid. It's probably hard for it to be slow. I mean, possibly what? Hospital melena, right? But if lower GI bleed is the right answer, right? Anything lower GI bleedish. I'm not going to differentiate which one's which, right? So if I don't think I'll put or put melena, but that's still lower GI bleed. That's what I want you to get from this is that lower GI bleed is diverticulosis, not diverticulitis. And that melena is an example, right? So a critical thinking question is, the patient has let's say has maroon stools, right? And then which one is it? Diverticulosis or diverticulitis. So you know that lower GI bleed is here, but do you know what lower GI bleed means, right? Or the patient has low H&H, which one of these disease processes might have caused that, right? Or the nurse is recommending high fiber diet. Which one is it for? It's actually for both, technically, right? Usually diverticulitis is kind of a complication of this one, right? What I just do. So diverticulitis. That makes sense. And diverticulosis causes diverticulitis. What does it say? If diverticulosis causes diverticulitis is a complication of diverticulosis, right? So that should link up, right? All right, so lower GI bleed. Anything else complication-wise? Perforation. I mean, you're kind of getting ahead of yourself because, yeah, diverticulitis can then lead to these symptoms, which can lead to complication of this, which can lead to UTI. It's like, is UTI a complication of diverticulosis? No, you'd have to get several steps away, right?
So it's like perforation would be more for diverticulosis.
Yeah, it's diverticulitis. It has perforation. Okay, so treatments for diverticulosis. It's non-pharm, right? Which is what? All diverticuli you recommend. Fix the underlying cause, right? That's always the right answer, but it's going to be what? We're going to do high fiber, right? High fluids, weight loss, which is diet and exercise is always the right answer. Anything else? Lose some age. You can't do that, right? Right. You can stop smoking. Stop. I mean, yeah, that's kind of weight loss, diet, exercise. You could do surgery. Yeah, stop heavy lifting. Right. Stop corsets, etc. Right. So complications are just see below. Right. Nurse interventions is non-pharm. Right. Nothing specific you're going to do. Right. It's kind of over here. Let's put under non-pharm. Right, there's no real pharmacological treatments. I mean, antibiotics, I mean, you could argue pain medications, right? All right, anything else we're missing here? Diverticulosis, that this line in the middle is. Let's do this one. Alt control. Yeah, there we go. All right, so anything else? All right, so how long did that take? To 15, 20 minutes tops, right? So you can see now that should be like a study session, right? And your study sessions, you should have like 4 to 5 of those, right? So you're, okay, guys, you're doing diverticulosis for diverticulitis, or we're doing Crohn's versus IBD, or versus ulcerative colitis, right? And we're going through X, Y, and Z. So you can see it's not a lot of information, right? So coming from the lecture notes, it looks like you could get lost in all the little details, right? But we're not testing you on little tiny fine details, right? We're testing you on the big concepts.
What you're testing.
Yeah, you can always ask me what's being tested. You can say, hey, do I have to know about all the different, I don't know, all the different meds and the side effects for IBD? No, I want you to recognize them and which one is for which one, right? I don't need you to know all the different, pathophys and which chemicals are involved and which pathways are highlighted. That's to help you understand why we have this treatment and why we have this complication and why we have X, Y, and Z. Okay, all right. So these guys are feverishly trying to finish their table before we shine a light on them. So let's go to our IBD stuff. Okay, so IBD. So what's IBD? What's it caused by? It's really not known. We know that Crohn's disease is Ashkenazi Jews, right? But autoimmune, unknown genetics. We know smoking's linked, right? Anything else we know about causes? It is an autoimmune process, genetic predisposition. I mean, you can argue maybe alcohol, but usually it affects like younger people in the 20s and 30s. Okay, so then symptoms. What are the symptoms? Good. You got abdominal pain, right? And specifics below. Because one's gonna be on the right, one's gonna be on the left, right? So diarrhea, bloating, they're not gonna feel good, right? And then diagnostic tests, yep, definitely colonoscopy, specifics below, right? So we know which one has skip lesions and which one has, continuous redness and such, right? Lead pipe. And CDAD rule out, yeah, that's going to be more for ulcerative colitis than Crohn's, but it's important, right? Labs, you got CBC, WC elevation, because these guys are inflamed. These guys kind of run hot and febrile a lot, baseline. BMP, what do we think about BMP? Why BMP? And they could be losing electrolytes if they have, right? So diarrhea has its own, that's a first semester fundamentals question, right? What is diarrhea and what are the causes of diarrhea and what are the complications of diarrhea? You know the symptoms, right? And then how you fix diarrhea, right? So that's kind of a fundamentals question. So you should kind of always think, oh, they've got fluid loss, right? And they also have electrolyte loss. Fluid light loss. That'd be something to recommend nurse interventions, right? Replace fluid electrolytes. It's like under non-pharm maybe. And non-pharm and nurse interventions do have a lot of overlap. Okay, so diarrhea management, right? Fluid lights. Not many other non-pharm things, right?
That's so funny. That was Lily for sure. Toxic. Oh my God.
Very good. So diarrhea management, pharm, we're gonna do steroids. Steroids are usually always given for exacerbations. Steroids lower inflammation, especially for exacerbations. Like when they call the GI doctor, says really getting out of control, the abdominal pain is horrible, they're gonna give them a course of steroids. Okay, if they're going to the hospital, they give them too. And we got biologics. Good. And then complications. Colon cancer, but especially who? especially the colon one, right? So ulcerative colitis, right? We've got dehydration, malnutrition, right? Especially Crohn's, right? We're kind of overlapped, but we get a little overview, right? And then ulcerative colitis causes were autoimmune and smoking, right? That's for both of them. And then what about symptoms? Let's colon down. Colon only, right? Colon only. We only got the colon involved with ulcerative colitis, right? That makes sense. So it's only the colon, not the ileum, right? It's like, which is what Crohn's disease had, right? So we can put down here, Crohn's disease affects colon, right? So most common is where? Terminal ileum and proximal colon, right? The ascending colon. Proximal ascending colon. Make sense? All right, going back to ulcerative colitis, they got tenesmus, right? And again, if you don't know what something means, put it in parentheses. Really, it's not so much the pain, it's just the feeling of something being left behind. I think I misspoke in lecture.
No, said, feeling like you can't fully.
Yeah, but tenesmus, I don't think has the pain attached to it. It's just the feeling, but it's not the pain associated. I think I misspoke. Right? Right, you got bloody stools for sure, right? Say more than Crohn's. I mean, you can even put CD, that way it's saves some space, but right, so pus, right, which is same thing. I was kind of put those together, pus and mucus. That's just an infectious process, right? It's not really due to gallbladder involvement. I mean, it could be fatty stools, maybe. It's kind of maybe reaching. I'll just say pus, mucus, and stools because it's an infectious process there. Okay, so colectomy. Very good as a treatment. Diagnostic test, let's put some diagnostic tests in there. Right, what are diagnostic tests? Good, colonoscopy, right? And we said we were going to specify below, what are they going to have in colonoscopy? Lead pipe, right? Continuous inflammation. Get rid of, okay. And then what about the other diagnostic tests? Yeah, you can do, infection, WBCs. But we kind of mentioned that above, so I don't want to repeat it. But these guys it's just the rectum is involved. We do a lot of STI testing, right? STI testing, infectious diarrhea testing. Right, so C. diff, salmonella, stool testing, right? And STI testing, they're doing all the things, right? Just to make sure that's not it, right? But usually if the history shows they've had it for like 3 months, that's not STI. Okay, and then colectomy is curative, other treatments, they got other stuff they can do, right? So that's where you get your meds. All right, you got like sulfasalazine. You have all kinds of other fun ones. Which one? Prednisone is, yeah, so steroids with exacerbations, so you can put that under complications. But they might be on steroids continuously, right?
Or specifically just UC, you had cyclosporin for the flare and
Lilumab, yeah. It's steroids, right, cyclosporine. But a big complication is toxic megacolon, right? Again, exacerbation, but also, let's put that up here. We get, let's put this extra what? Extra colon, extra intestinal symptoms, right?
Oh, there she goes, trying to-
It's fine. Right, of which there are several, right? So there are several, you just got to know like which ones are different, right? So extra intestinal down here. What's different about this one, right? Versus the one down here too. Right, because the one down here, Crohn's disease has like kidney stones, right? And gallstones, where I think this one has gallbladder too. It's just like colon, the inflammation, the gallbladder inflammation, gallbladder tree inflammation. All right, so like what is different? But it's everything. So it's eyes, it's not ears, but you got mouth can be involved, the skin can be involved. You get ulcers. So you put some like one or two examples for each, right? Ulcers, they're all the way down, right? And then what else? So ulcer colitis, prep for surgery, kind of makes sense, right? But what else? Really, it's a chronic disease. They have chronic pain, right? That's going to be over here. They might be on. That's kind of what their meds are for, to manage the pain too. Okay, so really, there's not too much teaching. I mean, obviously, quit smoking, right? There's not anything unique the way to teach them about. All right, increasing fiber in the diet. Yeah, it's like there's the diarrhea management over here that we talked about. Again, remember, see non-farm. Non-farm is basically a nurse intervention. Diarrhea management with fluid and electrolytes. It's the same thing for ulcer colitis. You're worried about fluid and electrolytes. You're worried about fluid loss. You're worried about blood loss. You're monitoring, H&H over here, WCs and H&H, blood loss. All right. All right, Crohn's disease real quick, right? Also known as CD, and it's also known as UC. Okay, so colonoscopy sees these things, but before we talk about the diagnostic tests, let's talk about the symptoms. What are your symptoms?
Weight loss.
Good. These guys have a lot more weight loss and malnutrition, right? So specifically like B12 and folate. These guys also have anemia, right? So iron is absorbed in terminal ileum. Well, it makes sense if it's inflaming the ileum, it's not going to absorb iron, right? Same thing where B12 and folate are absorbed. Okay, since the small intestine is involved, you can't absorb your fats as easily, so you can't get some steatorrhea too. All right, anything else we're missing from symptoms? So there's more diarrhea in ulcerative colitis, right? Because it's affecting, so let's put more in UC. Because it's affecting the large bowel, and the large bowel absorbs water, right? Due to large bowel. That's where it happens normally. So these little parentheses are important. That's what's going to help you understand these things, right? If you don't understand why colonoscopy is needed, you can put a little quick little note to yourself, right? You don't know why they need to be, or why we should resect the small bowel and not like the large bowel. It's because it affects the ileum, right? So putting parentheses afterwards is important. Otherwise, you're just memorizing, right? So this is important way to manipulate the information, but also we want to have a good rationale behind each one. Okay, these guys are much more have lost a lot more weight compared to someone with ulcerative colitis. Okay, and then colonoscopy shows what? Skip lesions, cobblestone appearance, right? That's colon and small intestine. Very good. Right, some of this general stuff sometimes, or like pathophys stuff, I sometimes I'll just put under over here, right? Just so I know that, so just some saving some space too, right? So like general stuff, right? So Ashkenazi Jews, fine, right? But there's some general stuff that wouldn't fit elsewhere. That way the table is not crazy long. Okay. Sometimes I used to just have like a column for general and pathophys because it helped me understand pretty much everything else. Right, but you can sometimes just fit that under the word. It's how you want to lay it out. It's just a suggestion. Okay. All right. Yeah. So finally, complications. You got fistulas, right? Oops. Fistulas, which leads to infection, right? And you can just put down what kind of fistulas, right? They have all the kind of the fistula like diverticuli have, but they also have the anal fistulas too, right? Because usually you're thinking that ulcerative colitis is all about the rectum and sigmoid, but it actually is that's the only time where Crohn's actually kind of overlaps a little bit commonly, right? Leading to infection. Okay, and it can perforate too, so just kind of like diverticulitis. Okay. All right, so you can fill this in with the other stuff we missed, right? But that's the idea, that you're putting this table together, and this is what you would study from, right? The perfect time to do this is, again, while you're listening to lecture, right? Or while you're prepping for lecture, while you're learning, in the 2 days after lecture, right? But you don't want to be making this table like, the weekend before or the weekend of the exam, right? It's too late at that point. You already had this made, and then you bring this to your study session, right? You bring this to if you don't have any friends, of course, you can just rewrite it, right? Or you can start teaching yourself. That's fine. Teach your cat, teach your dog, teach your house plant, whatever you need to do, right? To get this. Okay, we're talking about inflammatory bowel disease now. Here we go, right? And you should be able to get this information out. And he's like, oh shoot, I forgot about all those extraintestinal symptoms, right? And then when you're at your study group, this is where you can start asking questions. Like, so which one causes, has skip lesions, right? And you can, if you have a computer open, you can even bold it or put a little check mark if you have it printed out, right? So it's like, I already asked that question. What happened? All right. So I have skip lesions here. It's like, which one has kidney stones? That's your partner got it right. Okay. Which one affects Ashkenazi Jews? Okay, there we go. Right. Which one has this and this? And these are knowledge-based questions, right? You want to try to practice to try to get critical thinking questions. So you can say, like, which one causes, we didn't put that over here, but has high or has a risk of, you can try to fool them. So they start getting unintended weight loss, and they start getting coffee ground, or they got melanotic stools, right? Which one is it? Which one has the highest risk for IBD? It's ulcerative colitis, has his risk of colon cancer, right? Colon cancer is highest risk. It's like, well, how'd you get that? Well, that's colon cancer. How'd you get, why didn't you just tell me colon cancer? Because that colon cancer is a risk, a complication, but how do you understand colon cancer, right? You understand the words on the page, basically, right? So why would I teach someone to increase their fiber with inflammatory bowel disease? Oh, shoot, because they have a risk of diarrhea, right? So that you're trying to connect the dots in that capacity, not trying to just vomit out the information or diarrhea it out. Okay, so that's the idea, and that's the use of this, that you can get a lot of questions out of it, right? And nowadays you can just throw this in AI and have AI ask you 20 questions, and you have AI ask you 20 critical thinking questions too, right? If I take this information real quick here, just to show you that it is possible. Mouse is funky. All right, so let's do another chat session real quick. All right, give me 10 questions. You can, yeah, you can get the fancy account where it gives you.
Table I just started,
Mhm.
like, basically putting in your information into my table, but
Mhm.
that's not how you made your tables.
No, I try to make it as simple as possible, right? And you can have it, you can do like, say, hey,
Like, to be able to recall the things you've
Mhm.
been learning.
right? So I don't want to see the answers, right? So I just answer it, right? So real quick, which of the following is considered a potential cause of IBD? B, right? What's next? Common associated with ulcerative colitis compared to Crohn's disease. So with ulcerative colitis, not Crohn's disease. So weight loss, it could affect both, but weight loss is really Crohn's disease, right? Bloating and flatus, that's kind of both. That's very non-specific, right? But bloody stools is a lot more with, because they both have bloating flatus, they both have abdominal pain. Weight loss is Crohn's. So that leaves us bloody stools, right? Yes, bloody stools is both, but more bloody stools with ulcerative colitis, right? What finding colonoscopy is characteristic of ulcerative colitis? They got lead pipe, right? What about medication class used for reducing exacerbations? The steroids, right? Antibiotics are needed only if they have a fistula or an abscess that's formed, right? And then 5, which the following is an extraintestinal manifestation of IBD. Good, skin ulcers. All right, that's not the intestines. All right, what is a potential complication of Crohn's disease? So toxic megacolon is ulcerative colitis. Gallstones, yep, that checks off. Appendicitis, no, not really, right? It's in the right area. Hepatitis, no, that's a virus, right? And then which nutritional deficiency is seen in Crohn's disease? So because I put the rationale, it gave me better questions. Look at that. What surgical procedure can potentially be curative for ulcerative colitis? Total colectomy. And which of the following is an appropriate nurse intervention for managing diarrhea? Fiber, fluids, which one? This one's kind of a tie. And we specifically in our table said fluid electrolytes, right? Because they're losing a lot of fluid electrolytes. And you could argue that's more of a priority over fiber, right? So I'm going to get someone super dehydrated because they had diarrhea for 3 days. I'm going to fix the dehydration. Then I say, hey, let's increase your fiber too, right? Which statement best differentiates the two?
No. Because Crohn's disease has a skip lesion. CD involves.
So CD involves the whole GI tract, right? So ulcerative colitis only involves the colitis, right? Only involves the colon. So C is right? There we go. Okay. So you can say, give me the rationales for the correct and incorrect answers, right? Incorrect answers. Okay. Following the questions. So questions first, then the rationales, please. This came out after I made my tests. I use it for inspiration sometimes. Nowadays, I'm using a lot more for inspiration. All right, so here's the questions right here. All right, here's the rationales, and it gives you the correct, the rationales there as well. Yep, so let's do some real quick. All right, so let's go down here. Let's add this down here. We do diverticulitis. So here's some questions. Perfect, right? And then going back, I lost it. There it is. All right, so let's give me 4. Super hard, ridiculous, critical thinking questions with interpretation of lab results, throw an EKG in there. Yeah, don't give away the answer. And the stem, make me work for it. Go. Make them SATA too.
It's so crazy how fast it is.
All right, so 30-year-old, so EKG interpretation with abnormal labs. 30-year-old has Crohn's disease, has palpitations, fatigue, single episode. Labs show hemoglobin 9.5, KF 2.8. And again, for the next gen NCLEX, they give you the normal results. So I would give you the normal results as well. For electrolytes, you can argue like ABGs and electrolytes, you should know normals. That should be a safe thing. I think that's something we agreed upon. That's something you should know the normal values for, but I give it to you. Hemoglobin is 9.5, which is low. K is 2.8, max 1.2, which is low. pH is 7.48, which is alkalotic, which happens when you, what? We'll talk about it later. EKG shows prolonged QT interval. What should be considered in the management of the patient? Measure KCL. That sounds right. So how's it going to tell me? Should be giving me ABCD so I can give it the options, right? So 1. So let's give it A. What else? Potassium was low, so we just give potassium. There's probably a magnesium on there too. All right, was B correct? Administer calcium gluconate? No, that's a treatment for hyperkalemia. This is kind of getting outside of the thing. So I can give it my notes and say, don't go beyond these notes, right? So I have transcripts of the lectures here. So like, for instance, here we're talking about GI tubes and transcripts. So intestinal IBS, let's take that one and throw it in here. Oops. Four of them, and quiz me. All right, read the documents. Here's 4 questions based on just my content, right? All right, 50-year-old, this is a recap here, restart. 50-year-old has ulcerative colitis, has severe abdominal pain, distended abdomen. Vitals are low, a little bit low blood pressure, heart rate's elevated, respiratory is 24, temp is up, he has an infection, looks like, right? And his labs show white count of 25K, which is high. Hemoglobin 8.7, which is low, his bloody stools. Lactate of 5.6. That's kind of beyond this one. This might be a final question because we talk about lactate with sepsis. What complication and interventions would be prioritized? Has megacolon? Well, yeah, ulcerative colitis is megacolon, right? That works. So let's do 1, all right? A. B, administer antibiotics for suspected infection. That makes sense, right? Start high-dose steroids for flare-up. Yeah, if someone's coming to the hospital with a inflammatory bowel disease, they might need steroids. I think the distended abdomen is more, that's kind of beyond. That's I wouldn't ask that question, right? Asking you to start medications or stop medications, that's more of a nurse practitioner or MD role. That's not a role of a nurse at your level, right? Your job's not to know what to start. Your job is to know how to manage the medication once it's already started, right? If someone started steroids, what do you look out for, right? So can you expect steroids? Yeah.
The body is already under stress,
Mm-hmm.
so many things are increased already.
Yeah, if they have a severe infection like this, you probably don't want to give steroids. Okay. So then consider colectomy if conservative measures fail, I guess, right? I probably should ask like NCLEX style questions because it's asking more management style questions, probably because I'm studying for my boards. That's probably why, right? So, but anyways, we have initiate vasopressor support for septic shock. Again, that's more of a MedSurg 3 question. So it kind of failed us here, made them too difficult. So I made it too spicy, right? So I would say make these more entry level NCLEX level questions. Give me just 1 for now. Okay. Possible surgery. Yep, we said that. IV fluids. Yeah, they got low fluids. They probably had diarrhea, right? Administer high dose oral steroids immediately if they're ordered. If they're ordered, yeah. I mean, if they have ulcerative colitis, they could. I mean, that's still arguable. Initiate broad spectrum antibiotics. Yep, antibiotics are good. Antidiarrheal. Don't think so because the patient's bowels have slowed to a stop with toxic megacolon. Given antidiarrheals is not a great option, right? So not antidiarrheals and not steroids. Give me rationale for each. I've stopped asking for please. Stop saying please after a while. We'll find out if they, okay. Mr. High dose steroids, great. So we did get it right. So it gives you the rationale there too, right? And you can even talk to, if you buy the app, you can talk to it all day, right? You can have it, hey, quiz me on this. Okay, again, it's $20 a month. There's 2 months left. Right, November's coming up. I mean, you could splurge and throw. You make an account, it saves. I think for the pro version, but the free version can get you a lot of information, get you a lot. The pro version lets you upload stuff, so you can upload like a PDF, you can upload a PowerPoint. I think it should be able to read PowerPoint too. I think it has to be a certain size, and then but the text, if you guys want the transcripts of the lectures, I can give you those as well, right? So that you can upload the transcript and say, just write a question on this, just make a table out of this information. For instance, we're doing hepatitis on Monday. So for instance, transcripts of this one, let's do Hep A, right? So let's throw this in here and give me a table of Hep A, right? So what we say, causes, symptoms, diagnostic tests, treatments, and complications, and nurse interventions. Possibly. And I like to have everything in one cell. I don't want to, so let's make the columns go left to right and the relevant information. I think if I had 2 hepatitis, it would do it, right? And you can make it like, say, give me the bullet points, make it, I don't like columns. You can make it display how you like, and then I can just go ahead and throw this into my notes. It doesn't do the outline, unfortunately, but you got it right there. That's everything I mentioned in lecture, right?
Can we get those transcripts for everything?
Mm-hmm. Yeah, I mean, I can give you a lot of things. I try to not to give you too much things, and you're like, then you get overwhelmed. Like, what do I use? What I don't use? But I can make it organized and there. I could give like the audio as well. Yeah, I know not every college student can afford this, so I mean, and I can't share it, unfortunately. I can share the session, the AI session. I can share this session with you. Like I can share this and you can link to it. But you can't like create a thing. I bought the pro versions. Like when you take this one and you open it like in a incognito window, like if you were opening this is what it would look like. You would just see. I think there's like an enterprise level, but that's something like a college would buy for like all the teachers or something. Okay. Does that make sense? Covered everything we want to cover? All right. So hopefully that helped and didn't stress you out more, right? So we kind of went over a few things, learning. Again, I have a whole like 80-minute lecture on how to be successful in MedSurg too. Medication what?
For us to understand the.
Yeah, so give me, compare and contrast like pentamidine, right? And pantoprazole, IV push. I need to know I need to know the indications, the mechanism of action. I could have just copied this, couldn't I have? Compare this in table format. And then you look at it because we're still smarter than AI, so we still got to look at it, make sure. Oh, he never talked about that. Really, drowsiness. That's super random. That's super non-specific. I probably would not. That's not something testable. That's not something I would really look at, right? But EPS symptoms, yeah, that's for sure. Medical mind. And I probably add prolonged QTC, it didn't add it there. Again, it's just going based on what it knows, right? And you can have it like search the internet, right? So search, I don't know, trying to think of a good website, like not GoodRx, but some website, search the web to fill it in, right? So it has those things there. So yeah, AI has a lot of powerful uses to it, right? And again, it's still new, but there's still a lot of good stuff that can come from it. Search Medscape. So it gives you the link to the actual article if you want to like learn more. Right? It might have, you know, I don't know what else it might have added. That's a quick way. I mean, you really don't need a drug guide at this point. Like you're in the morning and you're like, hey, I have to give, you know, metoprolol to my super scary professor. What do I need to know? I can't read that much. I'm stressed. Give it to me in table format. Right? And if your professor gave you a table format they like to know, then that's it right there, right? And it's asking which one I like so it can be smarter than us later. Right? So there you go. Say, calm, you got this. Here you go. All right, so that way you're giving your medications. And you can say, hey, I'm giving 13 meds. Put it in table format, please. Colace, hydrochlorothiazide, right? Lasix, I'm giving metoprolol 2. I'm giving famotidine. I'm giving, what else? I'm giving methylprednisolone, methylpred, and what else? Another fancy one, right? Zinc, vitamin C, nephrocaps, atorvastatin, right? And sucralfate. There you go, vancomycin. So you can be super prepared, right? You can buy the glasses that have a little heads-up display. So it's like, I need glasses to see, since you can't have devices. And again, that's something that should be changed. I think you should have devices in the hospital setting if you using it for this, right? So indication, MOA, side effects, nurse interventions. All right, so $20 a month is much cheaper than however much your Davis drug guide cost as well. So it's very, very powerful, and you can add to it and do all kinds of things. You can even, it has memory. If you create an account, you can say, hey, my teacher said it's important to take this at nighttime. Make sure when I ask you in the future that you say take it nighttime, right? It'll keep that in there. Okay. All right, any other questions, concerns? All right, so don't hesitate to reach out to me if you have if any do come up. The podcast? Yeah. Yeah, I did it with AI. Not with ChatGPT, I did with Nopic LM, which is also free. You need a Google account. So if you have a Google account, then Nopic LM. So all I did was I uploaded I just gave the YouTube video actually. So because you can put like 100 sources really. You can get all kinds of sources. Like if you make the EKG document, PowerPoint's like officially, Google Slides works. PowerPoint's probably not. Maybe a PDF might work if you can read it. But usually the lecture notes or the lecture or like a transcript, you can take that as well. You take click to load. You can take I just took the link to the YouTube video, which is pretty much, then it reads the transcript and it makes a summary already. And then it creates you can do all kinds of things. You can do like a quick study guide off of it, right? Take a study guide off this, right? You can say, I want to make a briefing doc, like give me a quick briefing of what they went over, right? And then this is what I shared with you, this little podcast, 16 minutes. I thought it was less. So here's a little comprehensive study guide. Here's the key terms right here. Give me some questions, right? So it does everything for you. It's like it makes your notes for you. So like after I make a huge table like that, I'm like, I wasted time. Right? I can use AI to do it for me, and I can then edit it. Right? So there's all kinds of fun stuff you can do with that. All right, but it creates a whole like 2-person thing, which is pretty funny. And it makes mnemonics and such too, right? And you can ask it for mnemonics too, right? You can ask it for mnemonics. They may help me memorize this, help me give me an analogy to how it works, right? Give me an analogy to how a PPI works, right? It'll spell it out. If that doesn't make sense, then you can say, give me 3 more, right? So help you explain how something works, right? Here's the ketchup, and you squeeze it. It's a screw that tightens on the bottle, blocking the nozzle, preventing the release of acid in your stomach. It's a great analogy, right? It's like, I don't understand, VVI and pacers versus VVO, right? Help me differentiate VVI versus VVO pacing with an analogy. You can take a super complex concept, it'll differentiate it. Only steps in when someone doesn't belong, right? It's demand. VVI is a reactive guard, whereas VO is an overactive guard, pacing continuously, whether it's needed or not, right? So it's incredibly useful. There's a lot of things that are fun. Like someone said, in Google chat, explain this to me like Miss Rachel. It's like, say no more. So I had Googled me, to make it have it sound like Miss Rachel, and it was like murmurs, right? It's like, imagine you're in a house and then you're in the living room. You're not in the outdoor. So it's not aortic stenosis like the outdoor going out to the system. You're inside in mitral stenosis, right? It's trouble just getting into the main living area. So therefore, that's why I have stenosis right there. That's why it's not as symptomatic as aortic stenosis, right? So it's great at doing these things. All right. So any other questions? Again, reach out to me if there's anything comes up.